This is the fellow eye of a young male who had already performed a phacoemulsification. He had the same posterior nodal, almost symmetrical in the opposite eye, and was operated just a week prior to this eye being operated. And this is almost a retake of the earlier surgery. So initially, I go ahead with my 2.8 millimeter keratome incision, clear corneal incision, posterior limbal incision, and then place 2 side port incisions as well. And then I stain the capsule with trypan blue and expel both the trypan blue and the air bubble with 2% HPMC. Now I plan to make an oval rhexis in this case. And as I had said in the previous video also, that the reason for this is in the event of a PCR and we need the anterior capsular rhexis as support for a 3-piece IOL, then a larger horizontal flanges of the rhexis would be a very good support for a 3-piece IOL, and hence the oval rhexis. And you can see it's pretty easy to do it. You have to be careful at the tips of the oval part, because you are going towards the zonular area, should not migrate into that area and lose your rhexis. But other than that, it's pretty easy. And the whole thing has been done with just the cystitome. And once I have done that, I now plan to do only a hydrodelineation. I am only planning to separate the central core nucleus, and if possible bring it out and phaco only that part. There is no hydrodissection involved. And you have to be a little careful about this, because sometimes while doing hydrodelineation you can land up doing inadvertent hydrodissection. So I am using very small jets of BSS and targeting my area very precisely. After that, I even take a Sinskey hook and go in the area of separation and mechanically separate that. And this is very useful. You can mechanically separate it and almost bring it out. This is a very soft nucleus. He's only in his late 20s, so we don't expect a very hard nucleus in him. And now it is going to be very easy. Why I like to bring out the nucleus is sometimes when you are doing phaco and if you are within the lens complex, the infusion from your phaco handpiece can itself cause a hydrodissection. Now once I have taken out the nucleus, I'm going in IA mode and using the same phaco probe to try and bring out this Epi Nucleus. It's going to be very difficult to do it with the bimanual, so I'm trying to just loosen it, but everything has come out, including the posterior nodal part. But all is well. There is no breach in the capsule, and I am pretty confident in this case because after seeing how his fellow eye went. So with appropriate caution, it should go just as well. Going very slowly, not hurrying up anything, and trying to aspirate this epinucleus, and there, that's done. Now I leave the tip inside and fill in the chamber. I don't want any sudden fluctuations within the chamber. There was a little bit of that, but still you get the point. Even though there is no breach now, you have to remember that these posterior capsules sometimes are a little weak. So any sudden fluctuation within the anterior chamber can just open it up. So as far as possible, try to avoid these fluctuations. Don't come out suddenly with your irrigation probe. So now I am just very carefully stripping out the cortex and all seems to be going well. And that's done. I in fact go into the polishing mode and clean up those few fibers. This you have to be very careful about, but it is better to do this because these are very young patients and you really need to do a thorough job on them. Again, before I come out, I first fill in to avoid any sudden fluctuation in the antechamber, pushing in some viscoelastic, and I come out with my irrigation probe. So that done, just fill in some more viscoelastic, and then I inject my single piece foldable IOL. The leading haptic has gone right into the bag. The trailing haptic is out. I use a dialer and just tuck it in. I don't dial these lenses, I just try to tuck them in. And you can see the oval rex is actually helping me to do that very easily. Once the IOL is secure in the bag, I go ahead with my bimanual and start aspirating all the viscoelastic both in front as well as behind the IOL. Just making sure that all the viscoelastic is out. And finally I conclude the surgery by injecting my intracameral antibiotic and hydrating the wounds. Thank you for watching.